AMC Health is a consultative telehealth clearinghouse providing tailored packages of technologies and clinical and other support services required of successful telehealth programs. The customized end-to-end technology and support solutions that we help our partners build not only provide clinicians with the ability for remote interventions, but also with a continuous picture of patients' health and psychosocial status in between physician visits. The goal of these solutions is to provide continuous visibility into individual patients' health status and to empower each patient to take a more active role in managing their health and in improving their quality of life. We also connect patients with the right care at the right time to prevent or mitigate adverse events. During our 12 years of advancing monitored care, we have deployed many unique programs whereby the best that technology has to offer is threaded into existing clinical best practices, thereby dramatically improving the efficacy and the reach of those best practices. And there is no better example of that paradigm than Geisinger. We are extremely proud to be the telehealth development partner of Geisinger Health System, with whom we've worked for over 7 years now. Now, before we start, I'd like to offer a word on the context of the study being presented and why it's so significant in our space. The study, which was published in Population Health Management this past December, is notable not just for the duration of the analysis, which is unprecedented for a remote monitoring study, and the significant size of the cohort analyzed, but for the operational detail it provides and the description of the additive value these solutions have on top of existing complex care management interventions. If there is an overriding defect in the growing corpus of telehealth literature, it's that even the most well-designed studies are described in such sterile terms that readers are left with little or no information on how to conduct an implementation in the real world. And these studies are simply not interested in reporting this level of detail. In other words, the nuts and bolts of an effective remote monitoring program. So by the end of this presentation, I'm confident you will be better equipped to envision similar programs in your own environment.
Here, I just wanted to go over and make the point that this is not unique patients. So as Joanne said, we started our programs in 2008, but really we started looking at the data and counting in a meaningful way in 2009, and this is data through 2013. 2008 was really a building year for the program, lessons learned and tweaking processes. So these are not unique patients, but overall total enrollments, because certainly someone with heart failure can carry over and be in the program year after year. People, drop off, new ones come on. And then hospital discharge, certainly you could have someone who's been in the hospital more than one time. So again, this is just really showing that we've had enrollment throughout those 5 years of over 21,000 patients, not patients or members, but enrollments through that time period. So our current programs, we continue with the heart failure program. As Joanne mentioned, we have post-hospitalization for our TOC purposes with the IVR. We have a hypertension program that we do in concert with our nephrology department, and we have wellness kiosks, as Joanne mentioned, with our employer programs, our membership. So we utilize those kiosks to help manage in that space. In future, we're looking to do some pilots around diabetes. What can we do around COPD? And we're very excited. We'll be starting in the very near future using the video monitoring through smartphones, through kiosks and tablets. And in those spaces, it will be actually out in the patient's homes, utilizing case managers connected with non-clinical members of the team going into the home, and as well as using that in our nursing home space in both our case management and our medical management areas.
It seems like we can debate about the actual magnitude of these findings, but the consistent story here, I think, is that there is a statistically significant reductions in the odds of, or the probabilities of admissions and readmissions in terms of the 30-day or even 90-day readmissions, and or 11%, 10% cost savings, or total cost savings overall, which works out to be around ROI of 3.3. So I think one other methodological important point to be made here is the fact that when you calculate the ROI, we didn't actually take into consideration all the potentially higher administrative costs associated with having these tools. But I think the rationale here is that these are the activities, these are the times and efforts that would have been spent anyway as part of the case management efforts. So that was the rationale behind that. So we'd be happy to take any questions you guys have.
Some of the questions sort of get asked, it's essentially the same question asked in different ways, but why don't we start with how has the Geisinger physician community reacted to the telehealth monitoring? What was welcomed, what was not welcomed?
Okay. That's a great question. This is Joanne. I will tell you in the beginning, there were physicians that welcomed it, and there were physicians that did not welcome. What we really had to do was we proved ourselves. So, the first thing that Doreen had talked about is getting the right patient in. So if we enrolled the right patient and they were learning, the way that we thought they should, and we went to the physician and we wanted to make changes in their treatment, pull them in for, diuresis. So we had to prove that telehealth worked. And, today, how many years later, it's very accepted. And there are many times that physicians will say to case management, hey, did you get that patient on a scale? Or, is that patient getting some interactive voice response questions post-discharge to see if they're doing okay? So it took time to evolve, but we really had to prove ourselves. So once the physicians saw that it was effective and that the results that they saw, they were able to act upon. One value that this really has brought around weights is the ability to trend weights. So the physicians really like that the nurses could come to them with a trend showing what the patient's weight is every day, as opposed to just reacting to an elevation one day of the week.
Great, thank you. The next question is, which peripheral biometric devices do you use? Are you exploring others? And do you use one vendor for all of your telehealth program? In other words, IVR, blood pressure cuffs, etc., or do you use multiple vendors?
Advanced Monitored Caregiving, AMC Health, is our vendor. We have utilized the scales, obviously. We do have the Bluetooth-enabled BP cuffs that we use in a hypertension program that we work side by side with our nephrology department at Geisinger. Other devices that we will be utilizing in the future, we're looking at the glucometers, and we are also going to be undertaking an asthma study along with AMC for devices that will help measure compliance in utilization of inhalers and medications in the asthma community.
Great, thank you. Next question, could you please provide a description of a case manager's life before telehealth was introduced?
Okay. So crazy. I mean, as anyone who's a case manager knows, that it's even a little bit crazy with telehealth being involved in their daily. So they had Doreen said about 150 patients. And one thing that we have found out is the more touches, when we look at our outcomes, and we say, why is one clinic doing better than the other? We look at what the case management is doing with that patient. The more touches that we have for that patient really drives the outcomes. So the life of a case manager pre a scale would be the need to more frequently call a patient. So that heart failure patient, they may have to call every week, or actually even several times a week. So by bringing in the scale, now they can see live every day if there's any alerts and how the patient's doing. The other thing that's been very helpful is the idea that when the patient gets off that scale 3 times a week, that a phone call goes to the patient, and it's actually an IVR that's focused on heart failure. So now in turn, the physician and the case manager not only see the weight, they also have a set of questions that are asked. Because all of us know who work with heart failure patients, our treatment can't just be driven by a change in weight. We also have to know how the patient is doing.
Great, thank you. The next question is, have you had trouble scaling this program to the large numbers of members who've been through this?
A great deal of the volume was driven through our post-discharge IVR. So that is really about transitions of care in terms of getting the patients through that critical, first 30 days post-discharge. In terms of the scales, we have not, we grew from a pilot of 50. We averaged from 700 to 800, per month in the heart failure program. The length of stay on that program, we tend to keep patients in until, again, they are no longer with our insurance or until they have, expired, gone through the progression of their disease. And so we have not had issues in terms of scalability. We certainly have more than enough patients to take care of. I think that the challenge that Joanne and I would agree on is scalability is sometimes having the case managers embrace and utilize a technology, trusting that it can do the work that they would do, and that has taken us, through the years to gain that trust. But we would now have to rip the scale out of patients' hands and have, convince the nurse that they had to get rid of it. So in terms of scalability, that has not been an issue. I think that it's right. The most difficult part of that is, again, we have more than enough patients. It's what's the right technology, what's the right device, right patient, right care, right time.
Is there a cost to patients or providers to participate? And if not, who funds the program?
There is no cost to the patients or the providers. The funding of the program comes through the health plan, and how we continually fund our telemonitoring programs is through, again, looking at the ROI of the programs we've implemented and continually looking at what we want to implement in the future and ensuring that our motto really is that efficiency follows quality. So we want to put in quality programs where we will get that both the quality return on investment for the patient, and that allows us that return on investment from a business perspective to be able to put that money back into ourselves, into our own programs, and to continue to invest in both our patients, our membership, and our employees for these types of programs.